My name is Scott Johnson. I'm a professor in the Department of Psychology, and I also have an appointment here in Psychiatry and Biobehavioral Sciences. I will start off with an overview of my talk. So you'll be hearing a lot about ASD today, obviously, and I'll give my own little brief introduction about ASD in terms of definitions and characteristics. I'm going to focus today on, as Dan was saying, sort of a highlights of the last year, maybe the last year or two, in what we call baby SIBS research, and I'll flesh that out in a minute. I also want to stress the importance of a developmental approach. I am a developmental psychologist, as Dan said, and so I'm going to give you some insights that we as developmentalists can provide, hopefully, onto this research enterprise in ASD and trying to characterize its early manifestations. And then I'll focus on SIBS research in general, and then specifically the current three major theories about that are out there right now about what exactly ASD might be, and then that can help us frame some of the recent research to try to understand its early manifestations. And these theories, these are my own terms, but these theories really focus on social attention and social motivation. There's also theories that are more general than this that happen to cash out in terms of social impairments. And there's also the view, which nobody can deny actually, that ASDs are really heterogeneous and there may be multiple pathways to getting the diagnosis. And treatments really need to know about that as well. Talk about some major new findings, and then I'll summarize and take a look ahead. So, ASDs have been defined as neurodevelopmental disorders characterized by impairments in social function and social communication and the presence of restrictive and repetitive behaviors. And these three facets of ASDs will be evident in different ways in different individuals, but these are the big three clusters of symptom. Population prevalence is under some dispute. As you know, the diagnosis has been much more commonly applied in the past few years. But let's just say, for instance, for the sake of argument, that it's about 1%. It may be more, maybe less than that. Boys get a diagnosis much more frequently than do girls. We also know that ASDs are highly heritable, and Dan, of course, has done a lot of the seminal work in this field. Prevalence in simplex families, that is, families with one older sibling with ASD, your risk of getting a diagnosis if you're an infant is something like 20%. In multiplex families with more than one individual, close relative with ASD, it's substantially higher than that. And there are other reasons, which we'll hear about later in the day, to really focus on the heritability of ASD and what that can help us in terms of treatment and so forth. And then finally, ASDs are developmentally heterogeneous and genetically heterogeneous. They're just heterogeneous in every way. And so are the theories, by the way. As I said, I'll be focusing on baby SIBS research. What we do in baby SIBS research is we identify families. These families volunteer for us, of course. We identify the families who have a child with autism, and when they bring another child into the world, we want to know about them because we call that kid a baby SIB, a baby sibling of a child with autism. Because, as I was saying in the previous slide, ASDs are highly heritable, we follow these kids, we follow these baby SIBs, past age 3 at the point where they would have received a diagnosis. And then we can go back and look at their behaviors, and we can go back and look at whatever other measures we've taken, say measures of cortical function, and then we can try to see if there are distinctions between the kids who turn out to get the diagnosis and the kids who do not. So we call these high-risk kids. Some of the high-risk kids will get the diagnosis and some will not. The goals of SIBS research are, of course, to identify the early risk factors and to characterize the onset of ASD, because babies don't have autism per se, at least not that we can detect, but we can follow them and see when we can begin to see signs. We can also look to see if we can see signs in their neural maturation and growth. Another goal of SIBS research is to try to explain and characterize the heterogeneity of ASDs. And the reason for that is so we can understand the best way to treat the different kinds of ASD. And then finally, we want to map these discoveries from baby SIBS research onto concurrent discoveries in genetics and neurobiology. Okay, so that's a brief introduction to baby SIBS research. So again, as a developmental psychologist, I think a lot about, development, especially development in infancy. And so I just wanted to spend a few minutes talking about the importance of understanding development per se. The evidence is really, really mixed for pretty much anything you can think of when it has to do with ASD. What it is, what causes it, what the theories are, how to treat it. Because of this mixed behavioral and neural evidence, understanding the developmental time course of the onset of symptoms and the neural differences between kids who will get the diagnosis and kids who won't really does require understanding the developmental mechanisms that lead to these different phenomena. Again, treatment, the better the ability of us to understand the developmental time course of these symptoms, the better we'll be able to tailor different kinds of treatment approach to these different aspects of the disorder. And I also wanted to point out the idea of sensitive periods of development. The idea being that there are times in an individual's life when characteristics or learning mechanisms are most at play. A typical example that people always use of a critical period in humans is acquiring a language, or a sensitive period, I should say. So you can learn a language when you're 30, and you can learn a language when you're 1. It's easier for a child to pick up on language, and of course they do so apparently effortlessly, whereas when you're 30 and you try to learn a new language, it is laborious and very, very difficult, and you can never really do it as well. You'll miss out on some of the subtle grammatical distinctions that are characteristics of some languages and not others. You'll have an accent, for example, whereas young children get the grammar implicitly and they don't have an accent, et cetera, et cetera. Another really important example of a sensitive period, and this is more apropos to ASDs, is the idea of imprinting, which is a social bonding phenomenon that is seen here in these photographs of these geese. So these are, or maybe they're swans, I'm not sure. These birds over here at the left, and you can see the little ducklings or goslings or whatever they are following along one of the adults, and that's called imprinting. It turns out that the sensitive period for imprinting is very, very brief. It's probably about a day for a lot of avian species. So if you're around your mother for a few hours, you tend to, and a lot of avian species are just up and running right away after they hatch, you're just going to kind of follow that thing that you see, which happens to be your mother, and you're going to swim after her and walk after her and just try to be with her. That's imprinting. But it turns out, as you'll see in the middle picture there, this is Konrad Lorenz, the man who first described imprinting, discovered that a lot of avian species will actually imprint to anything, including him. So these, I'm not sure what happened to them when they grew up, but right now, when they're juveniles, they're perfectly happy to follow him around just as they would their mother. Now, is there a critical period in infancy for attachment, for the formation of close social bonds? The answer is a clear yes. And so we want to know during early infancy, for these kids, especially who are at risk for social impairments, how to try to bend those developmental trajectories towards healthy social relationships. Also, highlighting the importance of a developmental approach are some rather complex issues having to do with different systems in a child's life that develop at different rates. So a child is not just a unitary thing. A child is a collection of many, many, many different systems. Perceptual systems, cognitive systems, social systems, neural systems, physical growth. All of these things develop at different rates and they all interact. And it's really miraculous that anybody kind of turns out okay. These different structures and different abilities develop at different rates. Understanding how this works can help us understand how they fit together. Developmental studies can also help us understand how to, when there is something going off track, how to bring it back into line, as it were. So I've called this bending the developmental trajectory, bending the risk trajectory. So here's a couple of diagrams from a recent paper by Elzaba and Mark Johnson, just showing how we might think about the development across the first 3 years after birth of behavioral skills in typically developing children. I could use the pointer, I guess. In typically developing children here, and ASD here. ASD identified early tends to have worse symptomatology than ASD identified a little bit later, but they kind of end up in the same place. And then here's sort of a schematic representation of a child who kind of seems to be okay, but then there's regression, and then they end up getting the diagnosis, say, at age 3. Well, the idea behind bending the developmental trajectory is here's 2 different developmental tracks of ASD. The sort of y-axis here would be expression of risk. So this is the way an ASD would typically be manifest across the first 3 years. But then if we can figure out how to get them back on track, that's the goal of treatment. In preparing for the talk, I found it really helpful for me, and this will be maybe most helpful for those of us who are actually doing the research. But this is just an overview of all the labs, as far as I know, around the world who are doing baby SIBS research. As you can see, most of the sites are located in the US. There's some in Canada as well, and there are some here that are broadly North American, both US and Canada sites. There's a site in Israel, and there's a very, very productive site in the UK. But you can see UCLA is very, very well represented here in terms of at least the number of studies that have been published in the last, say, 10 years. But really, not to brag too much or anything like that, but really it's really spread throughout the country, and it's a very, very important endeavor, and so a lot of people are very, very interested in baby SIBS research in general. Not just autism research, but baby SIBS research. So it's really catching on. And here are some of the research topics that baby SIBS labs have been focusing on. So I'd like to point out a couple of things. I've parsed the graph into 2 parts. One is the number of reported measures that people are using to try to understand the developmental time course in baby SIBS. The number of papers since 2005 to about 3 years ago, and then the number of, measures, and the number of measures that have been employed in the past, say, 2 or 3 years. So notice a couple of things. First of all, the number of measures that people have been using is pretty steady from 2005 to 2011, but it's matched by the number of measures that people have been using the past couple of years. In other words, there's an explosion of research in this area. A second thing to point out is that if you just look at these first 3 bars, language communication, social referencing and joint attention, and social attention and face perception, these really tend to dominate SIBS research right now, these social impairments, and perhaps rightly so. There isn't a whole lot done on other aspects of baby SIBS, say, measures that we could be using. And I would like to come back to that later on in the talk and discuss the implications of those choices that the researchers, including those of us at UCLA, the choices that we make and what to study. Okay, now this is a very, very busy slide. I don't expect you to remember this, and I am not going to sit here and read it all. I put this up here only to highlight one thing, and that is, just to reiterate, I said this a minute ago, to reiterate just the explosion of research in the past couple of years. So if you look at the dates on these papers, with just a couple of exceptions, they're all within the last couple of years. The first paper that I know of, and you guys can correct me if I'm wrong, that published a study of baby SIBS per se was this one in 2005 by Lonnie Zwakenbaum. And his group continues to really push things forward in a very, very important way, but lots of other people have joined the fray as well. And this is just some examples of things that people are looking at. Okay, so let me move on now to the 3, as I see it anyway, the 3 major theories of ASD. So the first major theory is, you could call it social motivation or social attention. The idea that if social awareness, attention, motivation is the principal impairment in ASD, then what that means developmentally is attention to social targets in infancy is needed to establish social relationships. And if this is awry, if this system of forming attachments goes awry, then there are downstream developmental consequences. And none of them are good. Because these social relationships, we all need healthy social relationships, and they promote, normative brain and behavioral development. A second major theory I'll call more domain general theories. And they really have to do with brain growth. Cortical connectivity, that is connectivity between different regions of the cortex, if it itself is impaired, then this will, sort of by definition, impair communication between brain areas. How this cashes out into impaired social function is a question that I cannot answer, but there are theories about how that might be. So one is that this general issue of brain underconnectivity is particularly manifest in social communication impairments because social communication is so freaking complicated, and if your brain isn't working right, then that just kind of goes out the window. So this might particularly disrupt social function because because it's so complex, social behaviors are so complex, and attention to social signals is so difficult, that if the brain doesn't work right, then that doesn't work right either. And then finally, the third major theory, you could call the multiple pathways, you could also call it just general heterogeneity, and we'll hear a lot about this later in the day. There are significant individual differences in the extent and quality of symptoms and developmental trajectories and responses to treatment, and support for one magic silver bullet, whatever, that is the cause of autism, that just doesn't exist yet. So I'm going to talk about each of these three now in a little more detail, starting with social motivation. So there's a ton of research on this, a lot of research on this, and I'm just showing you one sort of somewhat older study now that shows that starting at about 12 months with different behaviors, kids who turn out to get a diagnosis of ASD really show different developmental trajectories in these behaviors than kids who are typically developing. So if you just kind of look at this graph, or these four graphs rather, you can think about looking at faces, smiles, vocalizations, engagement with an examiner, with an experimenter. And in young children, it looks like they're kind of the same as typically developing kids. The kids will turn out to have ASD. They don't get a diagnosis this early, of course, but when you go back and look, they don't look that different from typically developing kids younger than about 12 months, but then that's when the divergence really starts to happen, at about 12 months or so. So this was the sort of typical way of thinking up until very recently, when we started seeing this, as I said before, this real explosion of baby SIBS research that is starting to look at younger kids and seeing, or making claims anyway, of finding impairments or differences anyway, even as young as 6 months. So I wanted to talk about 3 studies that flesh out that idea. The first study I'll talk about comes from Mayada Elzaba and her colleagues. This came out in 2012, and I just want to take this slide and talk about some of the methods that we use real quick. So a very typical thing we'll do in a SIBS lab, for example at UCLA, we have very similar setup as this group in London. What you do is you get them in young. We get them in starting at 6 weeks actually here at UCLA. And we have a battery of assessments, assessments of cortical function and assessments of behavior. In this case, in the Elzaba study, what they did is they got them in young, between 6 and 10 months, and they measured their ERPs, which means event-related potential. And you can see this kid has what we call a net on with sensors that record electrical activity at the level of the scalp. In response to some event that you show the child, and the event is simply the onset of a face, making eye contact or not. I'll show you that in the next slide. So you want to know, what is the brain doing, like boom, immediately in the first second after the child sees the face or the eye contact or whatever it is. And we do this at UCLA as well, not with faces necessarily in the way that they do, but we have our own studies that I'm not going to go into. So you get an ERP at 6 to 10 months, and then you bring the child back. Very often the children will come back repeatedly for other assessments, but the critical thing here is children will get a diagnosis at, say, 2 or 3 years of either having an ASD or not. And the diagnosis, as you know, comes from an ADOS or clinical assessment or all of the above, all that sort of thing. So the children come back repeatedly at different ages. Testing here and then diagnosis here. So here's what they found. So the main point of the study was to see, is there a difference in the infant brain in their response to eye contact versus what we call averted gaze. So what you're seeing here is these sort of weird looking stimuli up here. These actually are the stimuli that the baby sees, but only one at a time, not 4 at a time. That would be a little overwhelming. So the child sees a face either making an averted gaze or eye contact, and then all of a sudden it switches to the other. So you see a face, the gaze is averted, and then boom, eye contact is made. And then boom, what does the brain do? Versus conditions in which you start off with eye contact and then the face looks away. Boom, what does the brain do? So these squiggly lines show for 3 groups of infants what the brain is doing. Starting here at time 0, this x-axis here shows time in milliseconds. Starting at time 0, that is the onset of the either averted or direct gaze. What is the brain doing? And then that's the end of the trial, basically, after in less than a second, 600 milliseconds later. So if you look at the green lines here, that's low-risk controls. These are kids who are brought from the general population who have very low risk of autism. They could get a diagnosis just like anybody else if they're one of the 1% who gets a diagnosis, 1% or so. But we assume that they're not going to have a diagnosis. Anyway, and we'll know that later on too. If you look at the difference between in these green lines between looking away, that is the averted gaze, versus looking towards, that is the direct gaze, you can see that in these low-risk kids, there was a big difference in their neural activity in these ERPs. Now, these humps here, these rises and falls, are different what we call components in the ERP. They have labels, P1, N290, P400. They reflect different kinds of cognitive and perceptual processing. I'm not going to go into what they are. The point is that the low-risk child's, these are an average of about, I think, 20 kids, so these low-risk children's brains definitely register a difference between direct and averted gaze. That's the point here. Now, if you take a look at the kids who are the same age, and they will go on to get a diagnosis of ASD, that is the orange lines, you can see that the brain makes very, very little distinction between direct and averted gaze. The third group, H, are no ASD. And their brains make some distinction, but not quite as much as the low-risk controls. And those same sorts of numbers are just sort of shown over here as averages in these different components, the P1, the N290, and the P400. The low-risk controls show the biggest difference in the brain between direct and averted gaze. The high-risk, no ASD, also shows differences, but the kids who turn out to get ASD either diagnosed early, that is these guys down here in the open symbols, or diagnosed at about 3 years, their brains don't show that same distinction. So the social attention of these kids who will get a diagnosis of ASD seems to be already impaired even at 6 months. This is not behavioral. This is not a behavioral study. This is strictly from ERP evidence. Okay, a second really important paper that stresses the necessity of understanding social motivation or social attention comes from the work of Warren Jones and Ami Klin. This paper came out late last year. And I'm going to introduce the study by showing a video that they used. They presented to babies who were, either SIBs or typically developing controls in the same manner that I just talked about in the previous study. So what happens is it's a very, very simple study. They just bring the kid into the lab, they sit the kid down, and they show a woman engaging in an infant-friendly fashion with the camera. So this is a video recording of a woman with a sing-song, a sort of infant-directed voice, and she's singing a song, and she's doing like Itsy Bitsy Spider, and et cetera, et cetera. Very, very simple video. What you see here, these sort of dots here, is the results from an eye tracker. An eye tracker is a device that measures very precisely where on a stimulus that your research participant is looking. And so this little trace here is an eye tracking record of a typically developing child, a low risk child, looks in the eyes, looks back and forth up here in the upper region of the face. Down here, this represents the eye track of a child who will get the diagnosis of ASD. The idea being that these kids tend to look at mouths more than eyes and would tend to look at sort of uninformative motions rather than trying to understand the identity of the person by looking in the eyes and things like that. The stimulus is coded in terms of eyes and mouth and basically other regions. That's what these gray pictures mean. So here's some results from that study. This is a group of typically developing kids. Again, the research design is similar to what I described before. The kids come in multiple times, in this case between 2 and 24 months. And they participate in exactly the same sort of a task as I just described. They sit down, they see the same woman again and again and again, 2, 3, 4, 5, 6 months, 9, 12, 15, 18 months, and 24 months. And they code from the eye tracking record, they code where the kid looks in terms of the eyes, in terms of the mouth, and in terms of looking at the body, and also in the background behind the woman, say, looking at the objects. So if you just sort of follow these developmental trajectories, this is the average of all these 25 kids. How often did they look at the eyes, that's shown here. How often did they look at the mouth, and then the body and the object. So, and then the main mean response here is shown in the solid line, and then these lighter lines show, it's called a 95% confidence interval. It's a measure of variability. So if you look at the typically developing kids, they start off making a lot of eye contact, or they look a lot at the model's eyes. Not so much at the mouth. That tends to gradually develop over the first year after birth, and that's consistent with a lot of research from developmental psychology that says as kids learn language, they start to pay more attention to the mouths of other people, and then less and less to the body and the object. So the kids are really paying attention to the woman, especially her eyes, typically developing kids. Now you take a look at a group of kids. It's a smaller n, a smaller number, because not very many kids in the sample would get autism naturally, unfortunately. But these kids, they start off looking at the eyes quite a bit. In fact, there's no statistically reliable difference between the typically developing group of kids and the kids who will develop autism. They start off looking kind of okay, but then eye contact, as it were, declines, and looking at the mouth shows much more of an increase. A principal components analysis, which is a specific kind of statistical analysis, will go through, the researchers went through, and they found the behaviors that seem to be most indicative of, most common in the two groups. And ASD was characterized by, the difference rather was characterized most strongly by the difference in eye contact, and so that's the principal component number 1. And it turns out that the extent to which in the autism group, the extent to which they looked at the eyes was related to their ADOS scores at 24 months. So that the less they looked at the eyes in infancy, the higher the ADOS score. And this difference was statistically reliable starting at about 12 months. And maintained statistical reliability after that. So the upside of this study is eye contact seems to be exceedingly important, but we can't tell from early on that a kid is going to be at risk for autism any more than they are by virtue of the fact that they're an infant sib. We can't tell just from their behavior at 6 months. It takes time for this behavior to develop after 6 months. And that's been really, this paper has really caused not just a ripple, but waves, and we've talked a lot about it in our group. Very important paper. Here's another very important paper from the group at Yale led by Chawarska. So it's kind of a similar idea. This is an eye tracking study again. And it's another study in which there's a model looking at the camera and saying nice things and using baby talk, et cetera, et cetera. It's a little more complicated. because there's a lot more to look at here that's very, very attractive. So we have these very, very interesting toys, the moose, the monkey, the penguin, and the rooster. And then she makes a peanut butter sandwich in the video. They coded the video in terms of, again, to code the eye tracking data, in terms of the eye and the mouth region, the body, and then the toys in the background. So the question is, when you follow these kids, where were they looking when they were 6 months old? This study is not a developmental study. It only looked at 6-month-olds. So here we have 4 groups that participated in the study, and they're all tested at 6 months. So these data all come from 6-month-old babies. A group of kids who turned out to have ASD, a group of high-risk babies. So these are baby SIBs who are not quite typical. Maybe they have, say, characterized as broader autism phenotype. Here's a high-risk group that actually doesn't turn out to have symptoms later on when they're toddlers. And here's a low-risk group. And the data here are very, very clear. Looking at the scene and at the person, the kids who turn out to have ASD later on when they're tested at 6 months show a lot less interest in the scene in general than the other groups. And they pay a lot less attention to the person than the other groups. So this study is really quite different than the one I just told you about. This study tells us that we really might be able to tell from behavior at 6 months. Not with perfect fidelity, of course. There's not a one-to-one correspondence, but perhaps, according to this study anyway, these careful measurements might be at least a clue or a sign that there could be something going on. Now, another important difference between this study and the previous one is we don't see differences in looking at the eyes, looking in the eye region, and looking at the mouth at 6 months. Only looking at the face and looking at the person. Now, why the discrepancy? I don't know. Okay, so those are 3 studies that highlight this idea of impairments in social attention, social motivation, as being an important characteristic of risk in ASD. The second theory I wanted to talk about, flesh it out a little bit, is the domain general theory. So I'll introduce this by talking about some work by Eric Hershen, who's a professor at UC San Diego. He's published a lot of very, very important, elegant papers describing what he calls accelerated brain growth in ASD, accelerated brain growth. So this is a diagram showing here, head circumference, a very, very simple measure. You just measure using a tape measure around the head. If you do this repeatedly across the first year after birth, and you look at kids who will turn out to have ASD later on versus typically developing controls, the kids who will develop a diagnosis of autism really kind of look okay early on, shortly after birth. But then sometime in the first year after birth, their heads really start to take off in terms of size, such that by the time they're about a year of age and then beyond, their heads are significantly larger. These blue lines here simply show, they're not data from individual children, they're norms from the Centers for Disease Control. And in other papers, Dr. Hershen has talked about specific regions of the cortex and some sort of subcortical regions as well that show this accelerated brain growth pattern. Specifically the frontal cortex, that's here, temporal cortex, cerebellum, and then deep inside the amygdala. And this is just a graph showing what I just told you. A second way, and this is a very new, very interesting paper, a second way in which the cortex of kids who have ASD might be different than typically developing children has to do with the accumulation of what's called cerebrospinal fluid, or CSF, in infants who are later diagnosed with ASD. So here's a typically developing child, and you recognize an image from an MRI, a magnetic resonance imaging study, and just slices through the brain, and you can see the brain. Here's a child with ASD, and you can see that a lot more of this white coloring indicates the fluid that surrounds your brain and mine and everybody's brain. They seem to have a lot more of it. And these are, over here on the right, these are simply graphs showing differences between different risk groups, ASD and developmental delays, and high risk typical and low risk typical in the accumulation of cerebral spinal fluid. And this graph over here shows from MRI images actually the size of the cortex. So this is a little bit more of a precise measure than measuring with a tape measure around the child's head. This confirms what Eric Hershen has been saying. Okay, so two important views of how the brains might be different in a general sense. Now, what about a brain being bigger in a general sense is going to lead to symptoms of ASD? That's a big question, and I'm not here to answer the question, but I am here to tell you that there are people working on the question. And here's one way in which people are working on the question. And this is another complicated slide, and I apologize. I'll walk you through it. What this group did is they looked at connectivity patterns, not regions per se, but pathways between brain regions, and the extent to which they might show abnormal developmental growth trajectories across, in this case, the first 2 years in ASD children versus high-risk infants who don't get the diagnosis. So ASD positive and ASD negative. So these are all SIBs who are in the study. And there are differences in these growth trajectories between these two groups. Specifically, the kids who don't get the diagnosis of autism show steady, strong growth in these connectivity patterns. So these diagrams here show specifically which white matter tracts or connections are being measured here. Now, the particulars are really not very important right now. They will become so in a minute. But this particular set of connections and this particular set of connections are ways in which parts of the left and right hemispheres communicate with each other. And these two diagrams here show tracts across the corpus callosum, that is interhemispheric connections, and different developmental trajectories, like I said. And here is a study that helps us understand what exactly that might mean. A study in which two kinds of visual attention were measured, and I'm not going to actually go into details because I'm running out of time, but suffice it to say that kids who have these impaired connections between the hemispheres across the corpus callosum tend to have slower oculomotor latencies. In other words, their eye movements to different targets, depending on the condition, are slowed. Their eye movement systems seem to be generally slower. The idea behind this study and trying to understand the specific impairments in ASD is if you're navigating a complex visual environment that's full of people, full of complicated stuff as a baby that you can't quite figure out, if you're not navigating this thing appropriately early on in infancy, then you're going to be in trouble later on because of these issues of sensitive periods like I was saying before. Okay, then moving on, I wanted to introduce the third major theory, the idea of multiple pathways, by showing a diagram from a paper by Dan Geschwind and Pat Levitt. And this is a very, very complicated diagram. I'm not going to walk through it, but it's complicated in a really interesting way because I was going to say it's like throwing up your hands. He's not throwing up his hands. Dan is not throwing up his hands. What he's saying is there is just so much about autism that we don't understand in terms of its massive, massive heterogeneity. Symptoms, neurobiology, etiology, genetics, anything you can think of. Why do we even call it autism? We should be calling it the autisms and trying to characterize the specific subtypes. A couple of papers that I will finish with have tried to do that. What this group did, this is Becky Landa's group at Johns Hopkins University, is they did a statistical analysis called latent class analysis of Mullen scores. And Mullen scales is a way of assessing developmental function in infants, and it goes up to, you can test babies as young as 6 months and up through 24 months. There are 5 subscales, and what they've done is they've applied the statistical analysis to try to understand developmental trajectories in kids who are at risk. Don't really have time to go into a lot of detail here, but I'll flesh this out a little bit. So the idea here is different kinds of developmental trajectory here that they call accelerated, normative, specific language and motor delays, and then just general developmental slowing. Unaffected kids, that is typically developing controls, by and large fall into these two classes. Kids with autism fall into these classes by and large, especially early identified kids, are really characterized by developmental slowing. And here's a diagram from the same group at a different paper showing some of the results from the Mullen and also some other assessments that they got. I should have labeled this. This is ASD. This is typical. And early diagnosed ASD. And this is late diagnosed ASD. And this is typical. And I didn't make these graphs, so I won't try to defend the use of teeny dots and then somewhat bigger dots. I didn't do that. But the solid line is pretty clear. But the idea is that these developmental trajectories are complex, and they really speak to the heterogeneity. Okay, I'll make one more point. Here's just a bit of a summary. Again, substantial challenges to any account of a primary underlying deficit. There really are inconsistent findings across labs, but you've got to realize that this has only been happening in the past couple of years. These new findings have come out. It's a real problem that the sample sizes are so small, and I'm not impugning the research at all. We have small sample sizes too. It's extremely difficult work. It's hard to find the participants. It's hard to get them to come back. And if you have a group of, say, 12 kids who have ASD, that's pretty good. But in a developmental psychology paper, like I would write with typically developing kids, 12 is like one condition out of, say, 10 in a paper. And that leads to another problem, which is replicability. A finding is always most confidence building when you can replicate it. And so replicating these things is very, very difficult. It's going to be years before we really know. One final point. Just looking at this diagram again, this graph, I highlighted the importance for a lot of the SIBS labs of these social impairments. But it's also true that there are cognitive impairments in children with ASD that start showing up, not at 6 months, but later on at 24 months. In pretty much any paper you see with autistics compared to typically developing controls, the IQs from whatever measure are always different, the IQ outcomes. What that means is these cognitive impairments, say in terms of learning and cognition, remain wide open questions. It's an important developmental outcome, but we know virtually nothing about it. It's a focus of some of our research here at UCLA. Okay, I will end there. Thank you for your attention. With respect to your first point, you're right that these theories are not mutually exclusive at all. It really has been a struggle for me the past couple of years to try and understand how the brain overgrowth leads to these more specific symptoms of ASD, and I'm not sure there really is a strong theory about how that is. So that I'm not sure is very commensurate, but in terms of the heterogeneity and the individual differences that we see in typically, I see hundreds of babies in my lab a year. And there's one thing that is characteristic of babies, and that is that they're wildly, wildly, wildly variable in what they do and completely unpredictable. So when you have a tiny group of 12 kids who happen to have ASD, although you don't know it yet, what can you expect? You can expect variability. So the fact that we get anything is actually, to my mind, really kind of remarkable. But it does remain for future research, including thus us in this room, to try to bring those together. Now, what should a child do when she's looking at a woman making a peanut butter sandwich? I don't know.